Afternoon where I am. I know it's 9 in the morning, Alabama. So good morning if you're in Alabama. Habari's Chana if you're in East Africa. Good afternoon, good evening wherever you are. So my name is Mike Vinacore. I'm a professor of infectious disease here at UAB, and I'll just give a little bit of background on our scientific working group focusing on GHRI. So this scientific working group forms part of the UAB Center for AIDS Research. So that's a NIH-funded center grant that helps our institution to support research on complicated, multidisciplinary, broad scientific goals. And so within our project, we often get the question, does it have to have HIV in the project? And the answer is, somehow it needs to be HIV associated, but we take a very broad definition. So we're really looking for global health work that is somehow we could say is tied back to HIV because of our sponsorship from the NIH Office of AIDS Research. But we take a pretty broad approach to that. Our scientific aims are to be a platform for UAB, and this is campus wide. So we really look for opportunities to reach across outside of the School of Medicine to other schools and be a place for scientific exchange, create networking opportunities, not just within UAB, but even more so to build bridges to other institutions, either local or international, and to catalyze and support new projects that can grow this type of work in the future. Recently, we've had several other seminars where we learned a lot about multiply adapting interventions across different settings in the HIV stigma domain, where there was actually a program that originated in Kenya and is now being used in Latin America because of through passing through Alabama at some point. So it was very interesting. And we also looked at some of the challenges and opportunities of using community health worker models, learning from Mozambique, and then Indiana University's team that's been doing this for a very long time and has been using the GHI framework for a while, came to present. And then in the second half of last year, we launched a pilot grant program where we had 13 applicants, and these all had to be projects that had elements of global health reciprocal innovation and had to have a PI in and a PI outside of UAB. And two groups were awarded in October. One is an investigator from Zambia together with an investigator from UAB looking at a physical activity intervention for cardiovascular risk reduction. And then the second is an investigator from the School of Public Health. And it looks like I didn't finish my slide, but their work is on HIV prevention using a game-based app for young people, including students and youth in Alabama. And then I also want to say that we have revamped our website. So if you are kind of curious about this topic, or maybe you're thinking about what is this, how do I get into this? What are the leading papers? We've tried to curate a bunch of resources on our website. And though many of them can be downloaded immediately, and otherwise you can link to the PubMed page. And so I just want to call your attention to the website. So, all right. So I have a brief introduction to our speakers. So we're delighted to welcome three distinguished researchers whose work has really transformed how mental health and behavioral interventions are delivered in resource-limited settings around the world. And that also includes underserved communities in the US. So first we have Dr. Florence Jaguga, who's if my research is correct, is a consultant psychiatrist and a researcher at Moi Teaching and Referral Hospital in Kenya. And her work centers on alcohol use disorder, task shifting, mental health interventions, and integrating mental health and substance use services into primary care settings around East Africa. And we have Miss Wilter Rono with a degree in psychology from Laikipia University in Kenya. And Wilter has conducted a wide range of community-based research projects focusing on mental health, substance use, HIV prevention, focusing a lot on rural and underserved populations, and has a lot of on-the-ground frontline experience. And then finally, we have Dr. Eve Puffer, an associate professor in psychology, neuroscience, and global health at Duke University. She's a licensed clinical psychologist and has research focusing on developing and evaluating community-based interventions for child mental health, family functioning, and HIV risk reduction. And she's worked not just in East Africa, but I noticed also in the Horn of Africa and in Thailand and in West Africa. So very broad background. So together, this is a great group for us to learn from in the Global Health Reciprocal Innovation area. And so join me in welcoming our speakers. And I'm passing the microphone over to whichever one of you is going to talk first. Thank you.
Thank you so much for having us. We are honored to be here. I have not spoken with a group about reciprocal innovation specifically. I don't think any of us have had a chance to speak with people who are really focused on this work. So I'm excited to talk a bit about what we've been doing in Kenya and the United States, and then hopefully have some rich discussion and hear what questions and thoughts that you all have. I'm going to get us started just very quickly, and then I will be passing it to Dr. Jaguga. Thank you, Mike, for the introduction. So I think I'll just jump right in and let Florence and Wilter also say hello as we keep moving forward. Today, we're going to talk about family-centered approaches, and our work is situated within global mental health, which I imagine many of you on this webinar also do. But to think about global mental health, we've had people, of course, doing international work in mental health for many, many years. But global mental health being recognized as a formal subfield of global health is something that is relatively newer and has developed over the past 20 years. And understandably, a lot of the focus has been on low and middle income countries. But what we and this group is helping us to recognize is that mental health disparities are, of course, something that happen all over the world, including in high income countries. And that has become a central guiding principle of our Center for Global Mental Health, and then certainly of the work that we've done that we're talking about today. So, Dr. Jaguga, I will pass it to you to talk a bit about the context for our work.
Thank you, Eve. So today we'll be focusing on global child and adolescent mental health. And we do know that the burden is very high within the global mental health space of global child and adolescent mental health. And the need for treatment in that area is really high. So 10 to 20% of children and adolescents worldwide have a mental health disorder. 1 in 7 adolescents have a mental health disorder. That's close to 166 million. Half of all mental health challenges present by 14 years, but often go undiagnosed. Close to 46,000 adolescents die by suicide each year, and that's our top 10 cause of death in that population. In low and middle income countries, less than 0.1 psychiatrists are there for every 100,000 young people. While in high income countries, the ratio is 1.2 child psychiatrists per 100,000 young people. Okay, next slide. So we'll first talk about our work in Kenya, and we've done our work in 2 locations in a rural village that does a lot of fishing. That's in the western part of Kenya, a place called Muhuru Bay. And then we've also done some work in a more urban area in a city called Eldoret, which is where I work as a psychiatrist at Moi Teaching and Referral Hospital. Next slide. So to give you a bit of context about Kenya as a country, 36% of people in Kenya live in poverty. So this means that they live on less than $1 in a day. About a third of women experience intimate partner violence. Half of the population, half of children experience childhood violence. Over 20% of adolescents have depression symptoms, and adult estimates of mental health conditions are 10 to 25%. And we have about 67 psychiatrists for 35 million people. So you can see that the burden of mental health conditions is high, but the number of mental health providers is quite low. Okay. So with such few specialists for a very large population, we cannot rely on specialists only to address the mental health burden. It's therefore important to think about other scalable solutions that can be implemented within the system to address this high burden of mental health conditions. Next slide.
So when we think about child and adolescent mental health, then we're thinking where we can move the needle. Our perspective has been based on this social ecological model, reminding us that child and adolescent mental health, all of our mental health is influenced by multiple layers, all the way from the individual to the societal and the cultural. The place that we'll focus today is on just one of the important levers that we can think about when we think about child and adolescent mental health interventions, which is that interpersonal level. And we'll focus on the ways that we have conceptualized and targeted the family level in particular. You'll hear us talk a lot today about the family system. And what we mean by taking a family systems approach or conceptualizing the family system is how families communicate, things like how much families trust one another, how they problem solve together, and whether or not there's violence present in that home. We think about the link from family well-being and the family system to mental health as happening in multiple ways. Some of those are through influencing the coping strategies and the resources that children have for coping, the level of hope that they have, and then their risk for depression and anxiety, and even more importantly, perhaps their road to recovery from mental health symptoms. We've looked at the associations between family well-being and mental health outcomes and investigated family interventions with some others on this webinar as well across many contexts, but we'll talk today about the work in Kenya and North Carolina. I'll start by talking about some of the very early formative work that we did in Uhuru Bay, Kenya, that was originally supported by the CFAR also at Duke and related to HIV risk and mental health. This was a mixed method study where we were looking at what are the psychosocial factors associated with adolescent mental health and their risk behaviors. And across the quantitative and qualitative results, family communication rose to the surface as central. Parents were expressing a lot of fear, shame, and lack of confidence around sensitive topics. That included sexual behavior. It also included communication around youth's emotions, communication about financial struggles, topics that were really difficult, but that were truly affecting youth's well-being. And that led to the development of our first family intervention as we thought about how do we address some of these mixed messages that youth are getting and open up communication within the family. So we started the development of Tuko Pamoja, which means we are together in Kiswahili. And our central goal was to help families become stronger and heal relationships. And that was to prevent mental health problems or to improve mental health problems and to reduce other public health problems such as violence. So these family-based interventions span both prevention and treatment. I'll talk first about the development of the prevention arm, and then Wilter will tell us more about the treatment. For both of these interventions, the tree is our central metaphor, symbolizing the family, which I'll tell you more about in a moment. Tuco Pamoja Family Days is the group-based prevention intervention part of Tuco Pamoja. It was developed in Mahuru with an advisory committee of youth and caregivers from the community using a CBPR process. And the resulting intervention blended the evidence base. This certainly wasn't the first HIV prevention communication-based program, so we had a lot to draw from, as well as very culturally anchored materials. Dr. Jaguga mentioned this was a fishing community, so for example, a lot of the metaphors, the skits, role plays were contextualized to include that major economic activity, and it also contributes to the risk situation for adolescents in the community. So a lot of culturally anchored material combined and then manualized into an intervention that in our first implementation had 9 settings. Family communication was at the center. And we did that across 3 modules: communication about poverty and stressors, emotional support, and then HIV prevention. Most of our interventions, and including this one, families are together for the majority of the time, communicating in the session as practice. But we did have some breakout groups as well. Happy to talk more about the evolution of this program over time. This is a universal prevention program. It's used a task sharing model is used for implementation with community-based lay providers. We look for established socially supportive settings, and in this case, churches were the most appropriate. So we implemented in churches in Mahuru and have done that since in Eldoret. And this is a group format with family members all together. We conducted a stepped wedge trial with 124 families across 4 churches with about 200 caregivers and youth. And what we found in that trial was that there were positive effects across multiple domains of communication, which is our primary outcome. And that included with mothers, with fathers, the whole family together, about economic stressors. So these are very promising results, especially for a universal prevention program. What these results showed us was that this could move the needle for a lot of types of families at different levels of need. But what was also very clear, and what I'm sure many of you are thinking, is that there are families who are experiencing current high levels of distress and current high levels of conflict. And this type of program might nudge in the right direction, but is probably not enough for those families who need more individualized help. And that is what led us to the work that we focused on in Eldoret, which was the treatment arm of Tuco Pamoja, which is Tuco Pamoja Home. And Wilter, I'll ask you to describe a little bit more about the Tuco Pamoja Home program.
Thank you, Eve. So I'll briefly describe Tuko Pamoja Home. Tuko Pamoja Home is a family therapy program for families with high level of distress, conflicts, distance, or mental health symptoms among the family members. It is designed to be delivered by non-specialists. These are natural counselors for contexts in which family therapists are not available. So to develop, I think that's slide now. To develop Tuko Pamoja Home, it started with a research to understand the internal family dynamics in families with high level of distress and what type of positive interaction would improve children and adolescents' mental health. We looked then at local helping practices. Who are these natural counselors already helping families with this type of problems? We took those findings and asked ourselves, which existing models of evidence-based family therapies addresses these patterns and could be streamlined for these natural helpers? Next slide. Based on the formative research, we developed a manualized intervention that combined elements for the other.
I think this one, yes.
Yes. I think it's the previous one. Tuko Pamoja Home Intervention?
I think you were, I think this one.
Okay. So before that, based on the formative research, we develop a manualized intervention that combines elements from family system therapy, solution-focused family therapies, and cognitive behavioral therapies. Families first complete an assessment with natural counselor, where they complete an orientation and family assessment using the central tree metaphor that Dr. Evers had mentioned. And then the counselor and the family choose which of these modules they need, depending on the problem the family wants to work on. The intervention is modular and is tailored to their specific area of problems. Next slide. Okay, within each module stated in the previous slide, there are 10 steps that the counselor walks the family through during the session. You can see the bold ones are some of the most important steps. That's step 1, 3, 7, and 9. Step 1, taking time to understand the family system, learning communication skills, using a miracle question to help them articulate how they want their family to be. And step 9, developing an action plan to work towards that vision. Next slide. So in Tuko Pamoja, the natural counselors uses videos to complement their counseling. So showing role play of another family going through this process. So you will see in that video, I was playing a role of a counselor. I won't play it all since it is in Swahili, but just to give you an idea, we'll play for a few seconds.
Lengo ambayo mnataka katika familia yenu. Na wakati wa majadiliano, muweze kukumbuka kutumia mbinu za clear. Hebu tuweze kujadiliana. Kama familia tuwe tukifanya kazi kwa pamoja.
Okay. I've been involved in Tuko Pamoja programs for more than 10 years now, acting as a lead trainer and a supervisor. So I have seen many families benefit from this process. I'm very happy to discuss more if we have time for questions at the end of this presentation. Back to you, Eve.
Florence, you can go ahead with our Lisa.
Thank you so much, Wilter. So we started with a proof of concept study, including case studies from 9 families counseled by 1 of 6 community-based natural counselors. And we had 2 main aims of that study. 1, we wanted to evaluate the implementation process to look at whether it was feasible for non-specialists to implement that intervention. And then we also wanted to look at preliminary effectiveness, pre and post clinical change. Next slide. So we found very interesting results. The implementation outcomes were positive, and the results supported feasibility and acceptability. We found 89% fidelity by the non-specialist counselors, supporting sufficient clinical skills. The families were able to complete treatment. We, however, found a challenge with scheduling of the sessions and further engagement. And we are working on solving the challenges of further engagement through a separate intervention that we have developed with other partners. And that separate intervention to improve further engagement is being piloted. We also found the intervention to be highly acceptable. The satisfaction was high, and it was congruent with the community routines. Next slide. Okay. For the pre and post findings, the results were consistent with indicators of positive pre-post change across various outcomes, whole family functioning, dyadic relationships, as well as individual mental health outcomes. Okay. And this gives us a signal that we may be successfully targeting these different aspects of the family system with Tuko Pamoja. Next slide.
Thank you, Florence and Wilter. We were all working on this project in Kenya, and we were preparing to integrate the prevention and treatment components, which we have done since then. But at that moment, COVID-19 hit, and so group-based interventions in churches, that type of research wasn't as safe to do. So when this happened, we had an opportunity from the Duke Global Health Institute to engage in some reciprocal innovation work. We, of course, saw that there was increased awareness of the lack of mental health services during COVID, which increased interest at our institution and health system in some of these more innovative task sharing approaches that had met with quite a bit of resistance before. And when we look at North Carolina, we see that the need may not be as great in some ways as we see in Kenya. It's different, but the situation is not positive. We have 1 in 5 adults, 1 in 6 youth experiencing mental illness. We rank 44th for access to mental health care. 72% of children who have a documented need for mental health care don't receive it. And 30% of Durham high school students self-reported depression in the past year. And I think looking at this, we're getting more buy-in that non-specialist delivered family programs have a place. So we took the Tuko Pamoja intervention, a combination of both the family days and the in-home curricula, and we adapted it into an 8-session intervention that could be delivered virtually called Coping Together. We of course did the cultural and linguistic contextualization, but we also of course then adapted the content and session structure and created multimedia materials to go alongside it. These were smaller groups. We had community health worker facilitators from a local community-based organization called Together for Resilient Youth. So their community health workers were the facilitators, with families still attending all together, but on Zoom screens in groups of 4 to 6. I'm going to show you just an example of the multimedia materials by showing an excerpt of a video that welcomes families into the program and also describes a little bit about what it's like.
And welcome to Coping Together. Before we get started, we wanted to remind you what Coping Together is all about and what it will be like over the course of the coming weeks. Some of you may have seen this video before, but let's review for those who haven't. Coping Together is a virtual program for the entire family. The purpose of Coping Together is to strengthen families. And we do this by helping families improve communication, better cope with stress, more effectively problem solve together, and to set a family vision for the future. In Coping Together, you and your family will meet with a group of 3 to 4 other families online for about an hour each week. Each group of families will have their very own trained facilitator who will lead all 8 weekly sessions and walk you through the program step by step. Coping Together sessions involve active group participation, but don't worry, it's actually pretty fun. Each week, you'll learn practical new skills, do fun activities and games with your family, watch videos, and participate in group discussions with the other families in your group. Sessions are especially great for families with kids between the ages of 10 and 17, but everyone's welcome to join. Oh, and did I mention, Coping Together is totally...
I'll stop it there, and the rest of the video also oriented families that this would be the first time the program was delivered in North Carolina and that they would be part of a research study on the proof of concept to see if families benefited from it. Here are the 8 sessions of coping together, and you can immediately see some similarities and some differences from Tuko Pamoja and the ways that some of the Family Days content and the home content were combined. Communication skills at the center, creating a family vision and goal setting played a more prominent role here in a more explicit way in the group, whereas it's more of a focus of Tuko Pamoja Home in Kenya, where families are working individually with a counselor. And then we apply some of those basic skills to problem solving, coping, conflict resolution, and solution focused action planning and graduation. The Tuko Pamoja tree is consistent across all versions of this intervention, with the trunk representing the adults, the children, the leaves, the branches, the relationships. And we have families reflect on, in Kenya and in the US, where their trees are very strong already, where they're a bit weaker, and how they can build that over the course of the program. With their roots, conceptualized as symbolizing values and internal and external supports for their families. The overarching goal is to become trees that can withstand storms, with storms being things that happen in our families and in our environments, including things like COVID-19 that we can't control and we can't avoid, but to figure out how we can apply those skills to reach some of our family vision and be the types of families that we want to be coping together, even when things are difficult. We conducted a pilot trial of the Coping Together intervention with 16 families in 6 groups. We had 24 youth and caregiver dyads, though more members of the family participated in the actual intervention, and 5 community health workers. This was a pre-post proof of concept similar to the pilot in Kenya, with intensive qualitative data collection, including some creative arts-based activities, and then complemented with survey measures that we also wanted to test themselves for implementation and pre-post change. We again found that the non-specialists were able to deliver with very high fidelity, and that there were high levels of acceptability in this setting as well, with the CHW providers, the convenience and ease of virtual delivery, and the high perceived relevance and usefulness of skills. There were so many benefits to virtual delivery, and people are still often opting for it in the new implementation since COVID as well. But there are challenges about technology support, inconsistent or partial attendance by some family members, and then some concerns in the study about mobile survey data collection, which is very common in virtually delivered interventions. So some concerns around that. When we looked at some of our quantitative data, one of the simple measures that we used was the inclusion of other in the self scale, which we've now started using more in Kenya as well, which we hadn't before. We looked at family closeness across the whole family and then the subsystems. And results across the qualitative data and the quantitative data signaled some improvements in overall family closeness. So you can see pre and post results on the iOS there, with one caregiver saying, "I felt at the beginning we were not deeply rooted." So she's referring to those values, those supports, but our tree has grown, our roots are deeper, and we have more roots, and the leaves, the children have gotten stronger. We then looked at the parent-child relationships, especially among those who were the target parent and target youth in the intervention. These are quotes from 2 youth. One of them saying they started off not on good communication terms, and we grew closer because we did talk more. Coping together helped. We had to go downstairs, sit at the computer, and talk to each other. And I do believe they meant had to, meaning they might not naturally have wanted to do that. But when they had this structure, many youth described that process of just talking more spending more time together did lead to improved closeness. This youth said, I wasn't feeling myself, but we had to go to coping together and had to start communicating. I was starting to tell my caregiver more of what was going on in my head. We had a lot of responses about how caregivers were receiving more thoughts from the youth, more of their opinions, more of their feelings, whereas the communication before coping together had been more factual about their needs or logistics. So we did learn about coping together that the intervention was perceived to be needed in the US. Before we embarked on coping together, we also had listening sessions with community-based organizations and really saw that shift to more acceptance and more recognition of a need for task sharing models, which I imagine is quite similar to the work that many of you here do as well. It was acceptable in the virtual format, feasible with community health workers, and we do see indicators of positive change. And these have been replicated in other pilot studies where we have tried slightly different implementation strategies, and we're now preparing for larger studies of the coping together intervention. Most recently, we've adapted coping together for Latinx families here in the United States, both in Durham, North Carolina, and in Milwaukee, Wisconsin. And that is called Caminando Juntos, which means walking together. And we are exploring school-partnered implementation models now that we have it available in both English and Spanish. And we're thinking about partnering with schools both in the US and Kenya. So we're thinking about those implementation models at the same time. And importantly, the reciprocal process is continuing. So we are applying a lot of the lessons that we've learned in the US about implementation, but also about content, especially in the mental health sessions, back to our implementation in Kenya. So Wilter and Florence and I are continually, if you imagine having both, all three interventions up on our screens all of the time, making changes to each one based on what we learn in each of the settings. So it's truly become reciprocal, I would say, especially in the past couple of years as we've wrapped up further pilot work in both places. I want to just highlight a few of our funders and collaborators, especially Professor David Ayuku, who was the co-PI, site PI on this project for more than 10 years before passing away. And since then, we've been very fortunate to have Dr. Edith Quoba and now Dr. Florence Jaguga taking on that PI role. And we have been very fortunate for Together for Resilient Youth, their director, Dr. Wanda Boone, who co-developed the Coping Together intervention with us. And we've had funding from Grand Challenges Canada, Duke Global Health Institute, the Basque Connections program at Duke as well, and many students and postdocs who have contributed a lot to this project. So with that, I think I will close and am very excited to hear questions and discussion, and especially excited for Florence and Wilter to share more about their experiences with whatever you're most curious about.
Thank you so much. That was really wonderful. And that's some incredibly important stuff. I'm sure that, like many of you, everyone, I was thinking of my own family and a bit during the presentation. So you just realize that this work is so fundamental to, well-being. Great. So we still have about 10 minutes for questions. Let me take a look in the chat. But I think if someone wants to just raise their hand using the Zoom hand raise function, that would be great. I can get us started. So I wanted to ask if Wilter and Florence had a chance to visit North Carolina, and what were they struck by in terms of differences that had to be dealt with in the adaptation process when bringing the Tuco Pamoja to the US. That's my first question.
Florence,
Yeah.
oh, sorry, go ahead, Wilter.
Yeah, let me go first. I haven't had a chance to visit North Carolina, but we've been working closely with Dr. Eve concerning the coping together and Tuko Pamoja interventions in Kenya. So I haven't had a
I've had a chance to visit North Carolina, and there are a couple of differences I do see between the circumstances in Kenya and the circumstances in North Carolina that would necessitate adapting the intervention to make it suitable for the situation in Kenya. I may not have heavily taken part in the adaptation process, and maybe Eve may be able to speak to it, but I must acknowledge that, the family situation in Kenya and the family situation in the US is definitely different. The dynamics, the manner in which communication happens in the family setting, the utilization of digital devices is different. So making it important that adaptation is done. So for me, the thing that stands out about transporting an intervention from one setting to another is acknowledging those different dynamics and being able to take into account when you're transporting the intervention. But I'll invite Eve to talk about the specifics of what the differences were when transporting this particular Tuko Pamoja from Kenya to the US.
That's great, Florence. Thank you. I'll say there were certainly cultural differences, but a lot of those were accounted for by the providers themselves. So by training community health workers on those same core components, when they implement the intervention and ask some of the same questions or give some of the same prompts, they are responding in a way that is culturally appropriate and tailored to what the families then bring to the intervention. So it looks very, very different, even though some of the prompts and activities look almost exactly the same. So it's interesting. We see all those differences Florence is thinking about, but they're coming out in the response and the interactions more in some ways than the content. We have found representation to be really important in our materials, multimedia materials, and that the investment in that should be significant, especially as we adapt to different populations in the US. So we're really thinking a lot about that. The Spanish adaptation was also, we had to identify some specific stressors. So for example, acculturation, and the enormous stressors associated with the immigration process. That is something that has to be adapted in the recent version that we did. But I think every situation we have to consider what's facing that particular population, because that's what's affecting the family dynamics. That's a huge part of their lives and what they deal with outside of the home. And so you can't, I don't think that we should sort of ignore any of that. Yeah.
That's great. So another thing which I think has been a little bit of a theme as we've started up this group is about some of the structural, like regulatory or licensing issues that may come up, especially when bringing things from low to high income settings where there are like 10 times more regulations and procedures sometimes. So I noticed that you mentioned that having community health workers deliver what I think we could call family therapy or some type of family therapy type of intervention. You listed that as feasible, but we'd also heard over the years that sometimes you have to be nuanced in the way you develop or deliver the intervention to otherwise then you are not able to use on someone who doesn't have a license, license like social worker, psychologist. So can you tell us a little more about the civil society organization or the community organization that delivered the intervention in North Carolina, and were they unlicensed or did they already have a background with appropriate like state licensure to do this? Over.
Yeah. Excellent question, and something we haven't solved yet. I don't think. The important thing about the coping together, though, is that it is not family therapy. So what we did for Tuko Pamoja Home that Wilter has trained and supervised in a lot follows more of a typical family therapy structure where you are very flexibly responding to the needs of highly distressed families. It is manualized and streamlined in a different way than family therapy often is. It's less manualized than other treatments often in the US when it's individual family therapy. And we did find that that process was feasible, and I believe that it would be feasible in the United States as well. But the way Coping Together is formatted, partially because of what the points you were just making, Mike, is positioned as a prevention, promotion, and early intervention program that is structured enough such that it would not be defined as therapeutic services. And the community health workers did not have any specialized degrees related to mental health or any licensure. But in the schools, it's interesting. We'll have to think about this again, who's identified as the providers, even if you're talking about psychosocial and not therapy.
Does that have implications for scaling it up? Like, people are looking for therapeutic, and instead this is a prevention program, or maybe if one day it was made as a for-profit initiative. I'm just curious if those design decisions you made will affect like how easily it's scaled. Over.
Mm-hmm. I think it could be good or limiting. It's certainly limiting for scale up in terms of an intervention being framed as a treatment. The interesting thing is we have the tools that we need to make it a treatment, to make it a therapeutic intervention from the Tuko Pamoja home. So we would push it further in that side to have a treatment arm, a true treatment arm in the United States. Now, one reason we're thinking about schools is to catch families early when this level of intensity could be really a good match for their level of need. But certainly, yes, certainly limitations. And I would like to see an even lighter touch version that's more promotion and a more intensive version that's more treatment. Yeah.
Thanks. We have a question from Chisomo Mwale. Go ahead.
Hello, thank you so much. Very interesting presentation. My question is more so for Dr. Florence and Dr. Wilter. Given that, so much of our family dynamics are influenced by culture, and given that the Tuko Pamoja programs were specifically targeting the personal portion of the socio-ecological model, would you say that these programs have actually influenced, cultural shifts regarding, how families interact with each other in the two areas where you implemented this program? Thank you.
Wilter, you can go first, then we'll go.
Yes, thank you. So I can say it has influenced because some of the things that causes conflict or distress in the family are cultural things. Like, for example, you heard Dr. Florence talking about the fathers not coming to the therapy. Those were some of the challenges because there is a culture whereby children and the father will not sit together and discuss on family issues. So it had influenced, but we can see Tuko Pamoja is a program whereby we teach families new skills. Like they come up with a new thing in the family. Like for example, eating together, having like 5 minutes talk per day together. So bringing them together we can see it has changed some cultures, and it has improved that the relationship and communication in that family. So those are some of the things that I can say Tuko Pamoja has influenced and has taken away some cultures that some of our people believe in. Maybe you can add on that, Dr. Florence.
No, and I totally agree with you. If you look at the family dynamic in Africa generally, it's heavily patriarchal, and children don't freely interact with parents. Expression of emotions, having conversations is not really the norm, especially between parents and children. So in that sense, by the intervention, allowing even communication and allowing interaction, then it challenges some of those cultural norms. It not only improves the mental health, but it challenges some of those cultural norms that can be harmful.
Thank you. Reina, question.
Thank you. This is really brilliant work by all of you. A huge congratulations on such a deep body of work. I had a question about the HIV prevention component of it and the work that you've done in that piece of the intervention. If one of you could comment on what that entails and what kind of measures you may have used to track how it's influencing whether it's self-efficacy or any other sort of measures or constructs related to HIV prevention. Thank you.
Sure, I will respond to that. We have only done the HIV prevention module in Mahuru Bay. The HIV rate, as many of you know, is much higher in that region of Kenya, right on Lake Victoria. And so our original research and funding was really focused on HIV. And what we found in the stepped wedge trial was that among the sexually active youth, there was more condom use related to participation in the intervention. And some shifts in sort of attitudes towards risky sexual behaviors and improved. We did quite a deep dive into the communication around sex and HIV risk, and we found specific improvements on those indicators. But interestingly, when we switched to Eldoret, where there's still significant HIV burden, and a lot of Florence's work is related to people living with HIV, it was less of an emphasis of our new funder. And we thought, well, the rates are lower. We'll replace that with some more in-depth mental health content, for example. And what we found, Wilter, if you remember in those early churches, was they found out that we used to have an HIV prevention module and about positive communication around sexuality and relationships, and asked for us to bring it back. So we've been in the process since then about building back in the time for that. And in Tuko Pamoja Home, we have a special session for teenagers where they have concerns about that. So we didn't have it on our slide, I don't think, Wilter, but there's a module specifically for sexual risk. But we haven't measured HIV prevention outcomes or had a large enough sample to do that since people select into that module. But we've been thinking a lot about it, Rena, so I'm glad to get your question and would love follow-up thoughts on it as well. Yeah.
Thank you. There's a question in the chat from our Global Health Institute director, Dr. Tita. Maybe I'll read out the question for him. He may be unable to unmute himself, but he was asking, and I think this is on a lot of people's minds. So in the current, health program and research funding landscape, where of course it's been a huge shock to the system in the last 12 months, how do you all, Wilter and Florence and Eve, do you think that this area of global health reciprocal innovation, bringing innovations between different settings, bidirectionally, what role does that play in how we go forward in the current environment? Any thoughts? Love to hear your opinions.
Florence, take that one first, and then I can follow up.
You know, reciprocal innovation is about taking innovations from low income settings and transporting them to high income settings. And I'd say that's really good return on investment for the funder, right? That's value for money, for the funder. So I think when we have dwindling funding, in the face of dwindling funding and people asking what's in it for us and people wanting value for money, I think it makes sense to strongly think about reciprocal innovation, to think about innovations that can be developed in low income settings, and then they also have mutual benefit for high income settings. So I see real potential for growth and benefit for reciprocal innovation.
I agree. And Florence was actually here recently in October and was a voice of hope around our institute around some of the potential for funding and creative ways of thinking around this reciprocal innovation. So I'm not sure I have other words of wisdom to add, except for I'm glad, as many of us probably are, that I was fortunate enough to have the opportunity to do reciprocal innovation before this moment, and genuinely invested in it and have that experience. And so when I hear things like that from Florence, I have ideas about directions that this could be an exciting way to go. And so together we can figure out how to frame those things and sources of funders who could also get excited about it.
Yeah, thank you. Does anyone else want to ask any other questions? We're down to the last 2 minutes. All right. Well, again, thank you so much for participating in our new Global Health Reciprocal Innovations group, which has only just started in the last year and a half. And so we hope we will get to meet in person at some events. And as I mentioned to everyone on the call, please take a look at our website if you're looking for more examples like this. Obviously, reading a paper will be nothing in comparison to hearing about the stories that our colleagues just told about their work. But you can get access to a lot of information there. And yeah, and really appreciate everyone's listening into this important talk this afternoon. So thank you so much. And finally, at the beginning, I forgot to acknowledge that the seminar is being co-hosted by our Global Health Institute, the Mary Hersink Institute of Global Health at UAB. And so we also have some participation from their side. And so thank you so much. Have a wonderful afternoon and evening. Good day.
Thank you.
Bye.
Bye.